Okay, and we should be live. Let me see here. I need to post on this one thing. So, I'm loading up. I'm loading up. I'm loading up. Let me click this over here. Click this. Click this. Copy. Paste. Go here. Click. Click. I'm clicking a couple things, guys. Give me a moment. Clicking, clicking. And then I go to Reddit. And then I go over here. And then I go to this new thing that I made. Where is it at? Amateur medicine. Create. Link. Paste. Post. Did I do it? Okay, I think I did it. Is it working though? What is this? Engage with your audience, start a Q&A, members only live stream, start a poll. I'm not doing any of that. Discord, I put that up. Hello, can you hear me? Okay, that's up, that's up. Then I go to Facebook, and then I go here. I gotta do so many things now, it's so hard. It's this group. Hey guys, I'm going to be live for some tutoring for an hour or two. If you have any questions, feel free to hop in. Paste. Post. Okay, that should be good. We're just gonna respond to some comments while we're waiting. Let's see. Great review, dude. This movie was phenomenal. We'll give it a like, a heart. Thank you. Thank you. I really enjoyed it as well. I think they did a phenomenal, did I spell that right? Job. They really showed lots of the highs and lows. Thanks for stopping by. This is what we do. This is what we do every day. If you guys want to know what it's like, it's a lot of it's responding and falling behind. The shorts, the comments on the shorts, they're too hard to reply to. Let me see here. Yeah, I don't remember what every single YouTube short is, so it's very hard for me to respond to this. Oh, they passed. Woo! Woo! Congratulations. So glad to hear that. Sounds like you worked very hard. Hopefully medic is next. I usually like to give him that. I usually like to give people kind of a, hey, you know what, you did a good job on your own too. And I can respect that. Quality video, of course. I agree. Let me see if I can do this here. Quality video, thank you. Thank you for your comment. I really appreciate it. I'm glad you enjoyed it. Thank you. Thank you. Let's see. Wow, these bedroom. Oh, yeah, I remember this comment. The heck, how do I do this? Okay. It's upright. So then do this. And then. Why can't I click play? Every time I click play, it disconnects. Is it working? Hello? I'm gonna assume that it's working. Anyway, while these bedrooms are broom closets, but I guess good job. Yeah, it's pretty tough. But surprisingly, I've actually seen worse. I'll be moving to the bigger station starting next week. So I'm very excited. Beautiful, beautiful work. Oh, this was a long one, but it was a nice one. Hey Mario, 2 weeks ago I took my NREMT exams and didn't pass. I came across your videos and started studying. You've been my mentor. Oh, this is such a nice comment. I didn't have the time to respond to it. Long story short, I retook the exam and passed. I'm happy. Tears. Thank you so much for everything you've done for me. Please let me know how I contribute to support your program. Thanks. I'm so glad you passed. Sounds like you worked extremely hard. Honestly, just your nice words are enough for me. But thank you for stopping by. Hopefully, Medic is next. Good luck with your educational journey. Beautiful, beautiful writing. Okay. Does anyone have any questions? Does anyone have any EMS questions? Anything at all? Or I'm going to keep responding to comments. Let's see. Awesome. Congratulations. Question. Did it let you stop early at 7090 or did you have a whole amount? I've heard conflicting things, but it the test will stop you generally at the earliest of 270 questions, but it can go all the way to 120 questions. It just depends on how you're doing overall. There you go. Let's see another question here. Truly think this video is the reason I passed the NRMT winning yesterday and took and passed my exam. Oh, that's very good to know. Congratulations. Sounds like you worked very hard. Generic answer, generic answer. I'm glad you passed. Thanks for stopping by and letting me know. Good luck on your studies. Guys, there's just so many comments that it's sometimes it's a little tough to keep up. These are just the comments I haven't responded to. There are other comments that I have responded to, but it takes a little bit. Let's see. I take my NRMT tomorrow. This review's been great. How did your test go? I hope it went well. And no problem. Reply. Let's see. Out of all the programs I use, I passed on my first try. Ooh, that's really hot. That's hot. That's hot. It's very true. Some instructors will mess you up. Will teach you the tricks of trades, but mess you up. Yes, you have to take the good with the bad. Still, sounds like you studied hard. Did a great job. Keep it up. Respond, respond. Good job, good job, good work. I just passed my NREMT on my first try in 70 questions. Thanks to this video. God bless this beautiful mustache man. The heck? Ah, yes, thank you. My mustache. Thank you for your comment. I'm glad you passed. Great job. How many times did you watch or how did you study? I recommend using amateurmedicine.com. There's a really good study bundle there that can help you with prepping for the NREMT. There you go. Like heart, like heart. Oh, okay. Did you use any other apps to study? I recommend using amateurmedicine.com. It has a really good study bundle for the NREMT. As part of the grind. He was right. They asked it with spleen. That was the first question. Congratulations. I'm glad you passed. Great job. And I know it's a clutch question to know. Okay, let's see what Phil says. Phil Miles says, "Hey man, just wanted to give you a huge thank you and a shout out. I watched a bunch of your videos and took notes on the longer ones before the NMT and passed on the first try. Thanks, man. Woo, woo. Phil, we love to hear that. Phil, I'm very happy to hear that. I guess I don't have to type to you, right? That's huge, Phil Miles. I'll throw you some hundreds just for that, some hearts. I can do a little bit of everything, right? I can just throw whatever. But congratulations. I'm very glad for you. Uh, I hope you keep up your educational journey. But that's phenomenal. Let's see here. But congratulations. And if you have any questions, by the way, any at all, EMS or medicine related, we can break down whatever you want. I'm just kind of killing time by responding to some of these questions. I usually don't go live at this time. I'll give you a like and heart also. I'd give your comment a like and heart, Phil, but I'm unable to at this time. So I just have to throw out those little things. I'm about to join an EMT course. This was awesome help. That's great to hear. Let me know if you ever have any questions. Post. Okay. Let's see here. Jack03555 says, okay, I'm just gonna like heart. That's a long, nice comment. It's a nice one. Thank you so much. Literally didn't take my test right after finishing the course. Like they said, I was stressing out. Trying to structure a good test prep, pocket prep helps, but not with all the small information to know off the top of your head. Well, let's see. Did you end up taking the NREMT? And I'm glad I could help. So respond. Thank you. Like, heart. Thanks for stopping. What the heck is that last comment? What the hell is that? I like the... What the helly? I'll respond to that later. Thanks for stopping by. I'm glad I could help. I don't know how to respond to this. We'll just we'll just we'll leave this one in the think tank for a bit. I had to find an appropriate way to respond. Let's see here. Just took right. Oh, hey, it's Seer. Good to see you, Seer. Good to see you. Yeah, well, I don't know how to respond to these comments, so we're just gonna kind of pass by it a little bit. I don't even want to put a like or heart because I gotta think of a clever response. But good to see you, Seer. How's it going? Do you have any EMS questions? I'm always happy to answer them. Right now, I'm just answering some comments that I kind of left behind. You had your first clinical a few days ago. Congratulations. How'd you enjoy it? That's very good to hear. Um, I always have a great recommendation. Let me see if I can find an image of it. Back of the box. This is something that I recommend. Back of the ambulance for students to do every time they do a write out. Okay, drag over here. Okay, so Seer, let me give you a little thing, not saying you don't do this or do this, but something that may assist you for your first clinical. I had some good preceptors and had 9 calls. Fantastic. Well, I'm glad you had good preceptors. Whenever you go into the field as an EMT-B, an AEMT, a paramedic, or so forth, you'll have the chance to also teach students that are riding out with you. That's something that they don't really teach you in EMS school, is as soon as you get turned out, you're potentially just going to be an educator right off the back. And that's for really any type of medical job whenever you have any students with you. Uh, so be ready for that, to be able to answer questions for students. If you have some old notes or something like a Google Doc, it doesn't hurt to like share it and recommend certain things. So I really enjoy that role as far as like a lead paramedic. Or even whenever I was an EMT-B, kind of going over the box with students, I find it to always be pretty fun. But anyway, let's say we're going to a call and you're in the back of the box. You're heading over to a cardiac arrest. Uh, and you're driving over. You're about 5 minutes away. Well, the advantage is if you know you're headed towards a cardiac arrest call and you have a driver and a lead, let's say like a medic or a lead EMT-B, doesn't matter, or AMT, and you're in the back here, you're not going to be as familiar with the box as the other two people. But what can you do? You can throw on your gloves. If you know that you're in the street, you can throw on a safety vest. You can open up the monitor and you can be like, what do I need to know first if it's a cardiac arrest? Where are my pads at, right? So open up your monitor slots, find out where the pads are at because you have 5 minutes driving to the call. Uh, if you are going to have a cardiac arrest, what's one of the immediate things you need? A BVM, right? So look in the airway cabinet and be like, here's where the bag valve mask is. That way, in case they're working the cardiac arrest and they're like, hey, I need someone on airway quick. You can quickly grab the BVM. Look for the OPA. Where's it at? Uh, Take a look at like your equipment while you're on the way. If you hear that it's a shooting and that might have caused it, what's something we may need? A tourniquet or an occlusive dressing. Find out where it is while you're in the back of the box on your way to your 911 call. Because you're not going to be as familiar with this box as anyone who's actually working full time. There's no way that's going to happen. That's impossible. But you have the chance while you're riding to a call to look into the different equipment. If I'm going to a diabetic call and I'm an EMT-B student, what am I doing? I'm looking at the medication bag and I'm trying to find where the oral glucose is. That way, if I have to administer it, I can administer it quickly because I know where it's at. So, just a little piece of advice. Not that you needed it in any way, but I found that once I thought in that kind of process, ride outs became really easy because I was like, well, I don't know where anything's at, but I have 5 minutes in the back of the box before we get on scene. I can look where everything's at. And I always tell students when they ride out with me, you don't need to know where everything is. You don't need to know where the 2x2 gauze is, right? But what do I expect you to know? I need you to know where the backboard is, where the pads are at, how to use the monitor. Where's my tourniquet at? Where's my bag valve mask at? If I'm putting a nasal cannula on a patient, I can probably wait a little bit, right? It's not the most immediate thing, but if I need to throw on a bag valve mask, I need to do that quickly, right? Because that's a more emergent thing. Uh, I don't care where the band-aids are at, but if we're going to an OB call, where's the OB kit? So kind of take that moment when you're heading to a 911 call and kind of refamiliarize yourself with the box super quick. Find where the pertinent stuff is, and then go from there. But that's something that I recommend to students whenever they ride out with me. And I find like it's a pretty strong one, you know? Uh, Also, gunshot calls are very easy to handle for like 90% of them. Most of the time, somebody's shot in the leg or something or the arm, and they're literally, I mean, their bleeding's controlled. They just got shot, and you just need to know how to ask the right questions and then to handle it appropriately. And then also play out for scene safety. But gunshot calls, I sleep on them. I know a lot of people would say like, "Oh, it's life or death," but I've had just not just about every gunshot call, but a decent amount. And for the most part, they're easy. And when they're not easy, they're either dead or they're critical. But it just depends. It's tough to say. Anyway, where were you? Oh, Shrill. It's Shrill. I remember you. Hey, just got home from medic school today. I'm tuning in to learn. Okay, Shrill, what did you go over with today? Shrill, what did you go over today? That's very exciting, Shrill. And good job going to medic school, knocking out your stuff. Let's see here. Let me move this out of the way. What happened to... Okay, a lot of ambulance calls. That's fine. Yeah, let me know, man. We can go over whatever you want or anything in between. Or I could just make up some stuff too. It's not really a big deal. Went over EKG rhythms. Ooh, Ooh, and your first drug quiz today. Okay. Well, what are some things I can talk to you about then? If we're going over drugs as a paramedic, what do you need to know, right? A really big distinction. If we're going over paramedic drugs, there's a couple that you need to know, right? Can I make this bigger? We could also go over EKG rhythms. I mean, honestly, it's whatever you want to do. Some big distinctions. That's like a pass or fail kind of thing. You need to know when to use Versed, when to use diazepam, when to use mag sulfate, right? So when do we use Versed? Versed's like the best drug ever, by the way, in my opinion at least. It's 1 to 5 milligrams. Max total is 10 milligrams. And of course, go by your school. This is just an example. Diazepam, we have generally it's 1 to 10, but I like to type it out as 2 to 10. I'm going to put it as 1 to 10 just for this. 1 to 10 milligrams. Max total is 20 milligrams. What does max total mean? That means that if I do a single dose at like 5 milligrams at the most, I can do another dose at another 5 milligrams, but I'm capping out at 10. And then I'm going to contact medical control if they're still seizing, right? For max sulfate, we do 2 to 4 milligrams. This is for seizures. We do 2 to 4 milligrams. Max total is 4 milligrams, right? And you need to know the distinction between these three, okay? What makes these separate? Mag is for pregnancy patients. Let's see. I'll put it right here. What the hell? Pregnancy patients, okay? Diazepam, Versed. The real distinction is Versed is amazing, right? Versed, you can give this IM, you can give this IN, you can give this IO, you can give this, what else is there? Intramuscularly, IV. You can do just about everything with it. For diazepam, you can really only give it IV, maybe IO. I'm not really too sure about that, honestly. Why is that the case? Diazepam, usually the way it's constituted, it's water soluble, doesn't do well in IM. That's just how I remember it. You really only want to give it IV, but there are occasions where we can consider giving diazepam. Diazepam is considered for rectal administration. Very odd. And I believe it's a weird dose. I think it's like 0.5 milligrams per kilogram. So you're really only doing this on like neonates, right? Because very quickly we reach like the 10 milligrams. Let's see, for neonates, infants, is really the only time we would consider something like this. But it's a very rare administration. A lot of medics aren't comfortable with it, including myself. But what would I do? I would get like a 1 cc or like a 3 cc syringe, and I probably like a 1, depending on how it's concentrated. And I would take off the needle, and I would just put the medication literally in and just administer it accordingly. I would try not to use a glass vial if possible. But I don't know if you apply a MAD device to it. I don't think you do, but I've never given a rectal medication, so that's tough to say. Anyway, really, if you look at these three, just know that mag sulfate is for pregnancy patients for either preeclampsia at 2 milligrams or eclampsia at 4 milligrams. I've seen somebody before where they took the national, back whenever there was a psychomotor test, where they chose to give a pregnant patient Versed, and it'll stop the seizure, but you're potentially going to kill the baby. So it's really not ideal. We do mag sulfate for this. What else do you need to know as a medication for a paramedic? Some big one, atropine, increases the heart rate, right? And we do this, we want to watch out for a second degree type 2 and third degree heart block. And I should put, it doesn't work on a second degree type 2 heart block and a third degree heart block. I'm sure you went over that in class today. But this is very important to know. If someone has a second degree type 2 heart block or a third degree heart block, we go straight to pacing. Okay, that's the distinction for whenever I'd consider atropine or when I'd consider pacing. Okay, and if I'm talking about atropine versus pacing, then a great question is, let me type this in here. If I have a patient who has a first degree heart block at 34 beats per minute, when will I distinguish? And this is a medic question, but it's good for anyone to know. When will I distinguish whether I will administer atropine or go straight to pacing? And let me fix this wording a little bit. When will I make this distinction? It's a great question. Does anyone know? I'll say the answer in a moment, but I'm just going to see. When will I be like, if they're stable or unstable? Exactly, right? So that's a great answer, Shrew. You're absolutely right. What are you looking for if someone's unstable? What distinguishes that? Right? So we're going between if they're stable or unstable. You're absolutely right. What's a huge, like an obvious sign where you'd be like, okay, this person is no longer in compensated shock. They're in decompensated shock. So we're going over compensated, versus decompensated shock now. What's the difference? The big difference. Does anyone know? I can give you the answer. Nice, Shane. Oh, good to see you, Shane. Nice. Hypotension, signs of cardiogenic shock, less than blood pressure like 90, blah, 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 blah. Exactly. So you're both right. The biggest thing, the biggest indicator is an altered mental status. Okay? That's going to be the biggest thing. As soon as my patient goes from talking to me, answering all my questions, to now he's verbally responsive or he's confused, I'm like, oh crap, there's no time for atropine. We don't want to do this medically. We want to go straight into pacing. Okay? Even if they are technically indicated to do atropine or pacing. However, what's another big thing for like decompensated shock? Decompensated shock versus compensated shock. Let me do compensated first. Compensated shock, you're going to see patients will maintain their blood pressure and their mental status. How will they compensate? They will have an increased heart rate, usually, and an increased respiratory rate. A normal blood pressure. For this patient, for instance, they're not going to have an increased heart rate if they have a first degree heart block, right? They're going to have a heart rate usually at like 30, 40 beats per minute. They can have a normal heart rate and it's visible. It just depends. But the big takeaway for this patient is they're going to have a normal blood pressure, right? That's what they're going to have. And a normal mental status, ANO times 4, or whatever their baseline is, right? However, if they're decompensated, they can't maintain their blood pressure. Usually, a patient's heart rate will decrease, respirations decrease from the normal range. Blood pressure is hypotensive, like Shane was talking about. They present with an altered mental status, like Shrew was talking about. Okay? So they're going to have hypotension. They're going to have an altered mental status. We can't waste our time administering atropine, even though it's indicated. We need to go straight into pacing. Okay, what's pacing for anyone who's an EMT-B and doesn't know yet? Pacing is basically whenever we continuously shock our patient, right? So pacing is when we continuously shock our patients. If we're considering pacing, if we can help it, if like we have two medics in the back, one can administer some Versed intranasally or something, or via IV to kind of sedate the patient as we're preparing to continuously shock them because it's not going to feel good, right? And there's a trick to pacing. We want to set it up on 8. Some people do it differently. I learned it as 80 on 80. We definitely technically, yeah, you can do milliamps. So what is the purpose of pacing? That's a great question. And I would do it a little bit different, Shrill. In school, I learned it as 60 on 80 or 60 on 60, and then we work our way up. So basically, what is pacing? Pacing EKG. Let's see if I can find one for you. Oop. That's a great question. So your patient's heart rate isn't being maintained naturally, right? And so, let's see if I can find a rhythm here. This is a wandering pacemaker. No. I just want to see a pacer. Can I find a good imagery of it? This isn't a good imagery, but this is basically what it'll look like on the monitor somewhat. So Shane, whenever the heart can't maintain an adequate rate, and so like let's say if their heart rate's at 30 or 40 and they start to present with an altered mental status, they're not perfusing properly. So we need to actually mechanically get the heart to beat on its own. So what we do, we'll introduce these small shocks continuously, and they can actually be pretty big at times, to get the heart into a rhythm where we're basically shocking and saying like, hey, stay at this rhythm, stay at this rhythm. And so we're shocking the heart itself, hoping that the heart will follow along with us. We're going to increase our milliamps, or we're going to increase the amount we shock them until the heart catches up with us. So basically, we're shocking the heart is the purpose of it, to get it to beat properly. And sometimes you'll see these pacer marks. Do you ever see these? Sometimes patients will have just pacers intrinsically. And so when you look at their EKG, you're going to be like, oh man, that looks so funky. But then you'll like see like these little lines sometimes. You can always ask them like, hey, do you have a pacer? If they do, okay. You're going to see like, it looks like an obvious heart attack. But if they have a pacer and they're not complaining of chest pain, just be like, all right, I'm just going to say you have a pacer and just say it's a pace rhythm and leave it at that. So the purpose of pacing is to exactly. So the purpose of pacing is to increase the heart rate to a rate where the patient can maintain adequate perfusion. So you're trying to increase the heart rate by resetting the pace manually. Exactly. And we can do that by shocking the patient continuously. So Shane brought up something, and pacing is from 50 milliamps to 200 milliamps. You're going to learn differently from school. Some will say 60 and so forth. Some will say 80 and so forth. I'm just going to say 80 on 80 because it's pretty easy to explain it. What does 80 on 80 mean? This means we are targeting a heart rate at 80 beats per minute, and we're starting at 80 milliamps. Yes, it's a ton of fun, Shane. And once you figure it out, it's very easy. It just takes some time. And we're starting at 80 milliamps. So it ultimately depends on the protocol. Exactly. In school, I learned 60 on 60. At work, we do 80 on 80. Okay? And so we're shocking our patient continuously, right? And we're trying to get them at 80 beats per minute from like their 34, and we're doing it at 80 milliamps. And so let's say I start and nothing changes. What am I going to do? I will keep it at 80 beats per minute. That's never going to change. But now I'm going to increase the milliamps. Some places will increase it by 10, some will increase it by 20. Let's say I increase it to 90 milliamps. And now I see on the EKG that the heart rate appears to be 80 beats per minute. So let me ask you this. We start pacing our patient. We're on 80 on 90. And their EKG went from 34 beats per minute to 80 beats per minute. Electrically, we can see it. Is that fine? Are we done there? So if I can actually do a poll, engage with your audience, start a poll. We start pacing our patient and we see electrically that the heart rate is 80 beats per minute while pacing. Oh, that's good. I'd have no room. Good. We can stop here. We're not done. Do a little poll. I we'll see what you guys say. So we're pacing our patient. We see electrically the heart rate is at 80 beats per minute. Is that so? The EKG is presenting at 80 beats per minute. Is that good or bad? Okay. Someone said we're not done. Any other guesses? 2 people say we're not done. Exactly, Shrill. Exactly. Leave it up for another 5 seconds or so. You can just guess, by the way. I don't care if you get it right or not, because we're going to talk about it. I'm going to go ahead and end the poll. You guys got it. Exactly. We need to check for mechanical capture. What is mechanical capture? It's when we can palpate, the keyword is palpate, a pulse at 80 beats per minute. Doesn't matter what it looks like electrically, all right? If the heart isn't actually mechanically, if it isn't squeezing at the correct time, then we don't care what it looks like electrically. So what do we need to do? If we don't have mechanical capture, but we have electrical capture, we need to increase it again to 100 milliamps now, right? Let's say if we're doing it by 10, some places do it by 20. Now we have electrical and, keyword and, mechanical capture. Fantastic. What do some places say to do now? Some places, I think my department does this too, will say, okay, you have mechanical capture. Now go down 5, I think it's either 5 or 10 milliamps. 5 or 10 milliamps until you lose capture. Then go up 5 more, regain mechanical capture, then lock in rate and leave it alone. Am I ever going to do that if I get mechanical capture? Hell no. Yeah, exactly. Hell no. I'm not doing that. I'm breaking the protocol. You're telling me I'm going to go through all that, get mechanical capture? I think so. But there's some wording of that in my capture. I'm not doing this. I'll just get in trouble, and maybe there's a lack of education on my part. I'm not doing this. I'm getting the rate and then I'm leaving it alone. They're mechanically perfusing, and I'm just going to say, oops, I forgot. I think it's dangerous. But there's a good rationale, and you don't want to shock them more than you have to. It's for patient care. It makes sense. Personally, exactly. Personally, I'm not gonna do this. But I need to let you guys know that some techs say to do that, and technically that's the correct way of going about it. If you are doing any type of assessment or education, or if you do this in the field and you stop right here, I think everyone's going to be fine with that. Personally, I would see that and I'd be like, all right, you did a good job. You saved your patient. I leave it at that. Okay, you're screwing around with your patient. Depending on your preceptor, especially if they don't know if this is a thing, which I don't blame them, they may say, okay, you've just killed your patient, and they're going to powwow with you and be like, what the heck are you doing? So I just had to tell you this because I need to know this at the station I work at, but I would leave this alone. Okay? But that's kind of the rationale on atropine and pacing. So we have atropine and pacing here, which is a pretty significant subsection of like knowing your medications for paramedic, and it also touches up on EKG rhythms. But there's another one too. We have adenosine slash we have adenosine and synchronized oops cardioversion. This is the other one, cardioversion. Okay, and let's see here. Adenosine. By the way, for atropine, you can do this in two different ways, right? Oh my goodness, we have so much typing just for atropine. For atropine, depending on where you're at, you're going to administer it at 0.5 milligrams up to a max total of 3 milligrams, or some places administer, and I think this is more so like the newer guidelines, is 1 milligrams up to a max total of 3 milligrams. Okay, so we do 0.5 milligrams up to 3 milligrams. Some places do 1 milligrams up to 3 milligrams for the total. It's perfectly fine. This is a paramedic drug. There's another use case for atropine before we go to adenosine. There's another use case for atropine. What is it? Okay, and this is very important for you to know. You're going to have a preceptor or like an instructor that's going to kind of be like, oh, you never knew. That's how it was for my whole class. We didn't learn this in class, and we had like a preceptor that hasn't been working with us. Exactly. It's for organophosphate poisoning. You're completely right. It's organophosphate poisoning. Okay, so you said it right. What are we looking for regarding this? Sledgeum. That's perfect. I like to use sledgeum. Some people use dumbbells. Basically, it's the same thing. We use sledgeum, and I should put it all in caps. You nailed it, though, Shrill. I think you're going to be a great medic. Sledgeum. It means, there you go, salivation, lacrimation, which just means crying or tears, urination, defecation. Oh yeah, no, I mean you're on it, man. You got it. Uh, GI, GI, right? It's such a useless term. Emesis, and then M. It's not. What is M? Meiosis. Oh, meiosis. I think means. Doesn't meiosis mean crying? Meiosis. Refers to excessive constriction of the eyes. I'm pretty sure this is sludgeum, right? Sludgeum means okay, meiosis, constriction of the pupils. Okay. Yeah, sorry. Yeah, you're on it. So, basically what are we seeing here when somebody's going through organophosphate poisoning? What's kind of the thing or the general theme in all these letters or all these words? Basically, is they're trying to get this stuff out of their body, right? They are emitting secretions through their mouth, through their eyes. They're peeing, they're defecating, they're vomiting. They have some GI issues going on, and their eyes are constricting. But basically, they're trying to get this stuff out. When we administer atropine to these patients as paramedics, what are we doing? We're trying to just dry them out, and halt the organophosphate poisoning. I kind of understand it. I kind of don't. But generally, if we see somebody, they may have gotten into like fertilizer or something like that. We're going to consider, hey, this may be a use case for atropine. And we're looking for these signs and symptoms. Okay, so it's important for us to recognize it. And then to not expose ourselves to the same organophosphate poisoning they're exposed to. But generally, you think fertilizer when you think of something like this. Somebody working in a garden or like some type of chemical plant, and they got exposed to something like this. Let's see. So, We have adenosine. Adenosine is a great one. Adenosine is used to decrease the heart rate. So if I wrote it correctly, atropine is to increase the heart rate for the most part. Okay, good, I did. That would have been a disaster if I wrote it wrong. Adenosine is used to decrease the heart rate, right? We basically are stopping the heart for a moment. You're going to see a small amount of asystole. That just means the medication's working. It has a narrow half-life, so we want to slam this medication generally in the left AC. So if it's possible, the left AC, or if we get an IO and the left IO, like in the humoral head, we can generally push this medication there. We can all, I mean, technically we can do it in other ACs. The left AC is the best one because it's closest to the heart and it's the biggest one. So if we can help it in all cases, we want to push this medication in the left AC quickly and follow it up with a flush quickly. How can you do that? You can use something that's called like a stopcock. It's let me type it in. Oh, I hope it's not a bad image. Please don't be a bad image. Okay, here it is. We'll have something like this. And what you're gonna do is you'll hook up your adenosine in one way. You'll have a saline bag over here, or like you'll have like a flush connected to it here or something, and you'll push both of them at the same time. Sear, well, it was so good to see you, buddy. Thanks for stopping by. It's good to see you, Sear. So you can use something along the lines of this, and it'll help you hook up your medication, and you can slam it. You can have your IV bag squeeze it or something, swap over to a flush, squeeze that too. You can utilize this somehow to quickly administer the medication at the same time. Let's get this out of here. Sometimes some agencies will carry that TP, sometimes they won't. It just depends on where you work at. But you'll push that medication depending on your protocols. Okay, it'll be different. You can either do for adenosine 6 milligrams, then 12 milligrams, then 12 milligrams for a total max dose of 30 milligrams. Or some places will do this: 12 milligrams, 12 milligrams, then 6 milligrams. Why they make that distinction, I don't know. But generally where I'm at, we do 6, then we do 12, then we do 12. If that's not the case, or if we're saying like, hey, they're not hemodynamically stable, which is the exact same thing like what we talked about for the decompensated shock, this one right here. They have an altered mental status. They have hypotension. Really, altered mental status is the big one, right? They have an increased heart rate. Then what do we need to do? We need to consider synchronized cardioversion. It's very important we press the sync button. Do we follow adenosine with the saline flush? Yes, we do. Yes, we do. And I should put followed by a saline flush. What I like to do is I like to grab like a saline bag, hook it up to the port, and then I'll kind of clamp it. I won't clamp it. I'll hook up the adenosine to the closest port to the IV, and then I'll slam the adenosine, and then I'll follow it up by having somebody squeeze the saline bag. I'll disconnect it, and then I'll push another saline flush. So what does that look like? It's so easy for me to say, but why don't I show you? Ooh, that's not good. Basically, if this is my patient, and I'm accessing this IV port right here, so this is my saline, and then I have my little IV port going to the line. There will be 2 people. Person number 1 will be here, which just make you really small. They're going to be accessing the closest port right here, right? And then I'll put here lead medic. Can I make this bigger? Will be pushing adenosine. Beautiful, beautiful. Some of my finest work. And then with your other hand, right here, also right above, exactly. Also right above, squeezing the saline port for the bag, right? Basically, what am I saying? With your other hand, right here, right above the port, you're going to be kind of squeezing it or like bending it in a way so that the adenosine can't travel upwards. It can only travel downwards, right? At the same time, you have your second lad right here, right? Your second lad. Let's see here. Second person squeezing the bag or using a BP cuff on the saline bag just to compress it, just because we want to push as much saline as we can as quickly as we can. So the lead medic's job will be to push adenosine while pinching this port spot right here, followed up. Let me see if I can put this here. Followed up by a saline flush. So this is a very dynamic medication, right? We're hooking, if you're a competent medic, right? You have your partner here. He's going to get ready to squeeze the saline bag as soon as you say so. You're setting up. You've got your adenosine hooked up to the closest IV port to their IV site. You're going to hook up the adenosine. Tell them on three, okay, ready, set. You push your adenosine. Then you open up this port. He's squeezing the bag. You're disconnecting the adenosine. You are hooking up your saline flush. You're pushing your saline flush. And it's all in a very swift, fluid motion. You're going to see that you're going to struggle hooking up the saline flush. But it's okay because you have somebody squeezing the bag the whole time. We want to try to go for a nice IV port or an IV site of like an 18 gauge if you can help it. It just helps you push in more fluids faster. And you're going to see the heart restart. And so the heart will go from a very fast rhythm. So like if it's very fast, it's going to look like something. You might not even see the actual P wave anymore. You're just going to see a bunch of QRSs. Hopefully they're narrow and tight. They're not a ventricle rhythm, right? Because then we're feeling for a pulse to see if it's cardiac arrest. And then all of a sudden you push the adenosine and now you got a flat line. And then you're hoping after you push the adenosine that it starts to reset. And then you have a normal rhythm. That's what you're hoping for. May have to do it a couple times. And then just continuous. Sorry about my bad drawing, but this is generally what we're expecting it to look like, right? From a run of like SVT to a flat line to a sinus rhythm. I think that's pretty accurate, honestly. So, SVT rhythm. We're going to get a systole. It's going to hurt the patient. It's going to be very scary. Then we're going to have a parentheses normal. Oops. Rhythm. This is what we're expecting it to look like for whenever we push adenosine. And then also if we synchronize cardioversion at the same time. The only difference for synchronized cardioversion is you're going to see the pacer mark or the synchronized mark. And basically you're just going to see a little black line everywhere on every beat. I think it's right about here. It might actually be on the actual R wave itself. Or so it'll be like this. Let me erase this here. Let me see if I can pull up an image of, there we go. SVT with synchronized cardioversion. Show me synchronized cardioversion, what it looks like. Let me just type in this. Come on. You gotta have it somewhere. Synchronized cardioversion rhythm. They've got to have something on Google about it. This guy's just in the same rhythm. Let's see here. Here's one. It's not really a good imagery, but basically you're going to see some type of like indicator or something along those lines that your monitor has started to synchronize with your patient, right? So we have like a synchronized cardioversion, and he didn't even have like a bout of asystole. He just went straight into a sinus rhythm, which is fantastic. As you can see right here. Beautiful, beautiful. We need to be very careful. We always need to do a synchronized cardioversion. The reason being, if we do not synchronize cardiovert, and I think it's whenever you hit in the second half of the T wave, right here. Oops. So if we zoom in right here, I actually just remember going over this. If we synchronize cardiovert somebody, or we don't synchronize cardiovert and we shock somebody, and we hit them in the second, or is it the first half? It's either the first or the second half of the T wave. Might actually be the first half right here. If we accidentally shock them at this part where the heart is resetting, then it's going to basically cause the heart to squeeze after it just squeezed. So it had no time to reset, and you're going to cause your patient to go into a dysrhythmia where they're going to go into VFib. So they'll start to present like this. Right? Because you didn't synchronize cardiovert them, and you didn't hit them here, you didn't hit them here, you accidentally got the 1 in a million chance to hit them in the first part of the T wave, or the first part of the ventricle resetting. And so you need to be very careful. You need to synchronize cardiovert these patients. It's very important that you do that. I kind of like how this looks. It looks kind of cool. So we synchronize cardiovert. Some places will teach you differently. Some places will say 100 joules, then 150 joules, then 200 joules. I'm used to it being 150 joules. Oops. Then, oops. Then 200 joules afterwards until it fixes. So basically, I'll have a patient and I'll start at 150 joules. I'll synchronize cardiovert them. And then if that doesn't work, then the sync button should still be on. I will synchronize cardiovert them at 200 joules, and then I'll just keep doing that. And then occasionally I might slip in like a Versed administration. But if I can fix this with adenosine, then I will fix it with adenosine. Just food for thought. Let's see. We can go more into paramedic questions. Really big thing that you're going to need to know is the clock method. Let me see this. I'm going to save this. I kind of like how this looks. File, save as. Oh, good. It popped up there. Let's see. Cardioversion. That's what I'm going to save it as. Let's make a new paint. Whoop. One thing that you're going to need to learn really well, Shrill, if you haven't learned it by now, is the clock method. The clock method is something that you're going to use throughout a lot of your EMS career for only the complicated medications. Okay, so we really need to know how to use the clock method. What's the clock method? Let's do an example here for lidocaine. Nice. Lidocaine example. Uh, if you have you can have a premix where it's 1 to 4 milligrams. I believe that's correct per minute using the clock method. Where if it's tough for me to say, but if it's administered in the correct dosing, I think it's I think it's a bag of like 800 micrograms or 800 milligram. No, no. Is it 2 milligrams and 800 lidocaine premix bag and 800 mLs, right? Let's see here. Some 2 grams in 500 mLs. Okay, okay, okay. This is it. This is it. This is the type of lidocaine that you're gonna get. Sorry, guys. It's very complicated for me to talk about this. This is a common premix that you're gonna get. You guys might not be able to see it too well, but this is lidocaine, or what we have here. Lidocaine, 2 grams. Oops. Give me that. 2 grams in 500 mLs. It's mixed this way. I'll put this in red. It's mixed this way in a very particular reason. Why? Because now we can use the clock method for it, okay? Same thing, and I guess, yeah, 1 to 4 milligrams per minute. That's correct. Basically, because it's mixed in this particular setting, we can use the clock method for it. What's the clock method going to look like? It's going to be split up 4 ways. And it's so simple once you figure out how to actually utilize it. It's very simple, but it's easy to forget if you don't practice it. Okay? We start off at the clock. If we want to administer 1 milligram, where I should say 60 drops, or I'm not going to say it, but 60 drops would be like 60 seconds. Where if this was a whole minute, if I want to do 1 milligram, 15 drops in 1 minute. Okay. Can I make like a little line here? Okay. If I'm using the clock method, 1 milligram is going to be 15 drops in 1 minute. All I'm going to do is I'm going to set my lidocaine drip set to administer 15 drops in 1 minute. What's another way to say? I'm going to do 1 drop every 4 seconds to reach 15 drops in a minute. If I wanted to do 2 milligrams in a minute, 2 milligrams is 30 drops in 1 minute. So that's how I can titrate it. Okay? If I want to administer 3 milligrams to a patient, 3 milligrams is 45 drops in 1 minute. Okay, so with an example like this, if 1 milligram is 15 drops, 2 milligrams is 30 drops, 3 milligrams is 45 drops, what do you think 4 milligrams is going to be at? How many drops in a minute? We'll say it right here. And then right here. So then I'm gonna. It's a tough question to ask. Exactly. 4 milligrams is 60 drops in 1 minute. Exactly. And how many drops is 60 drops in a minute? It's a drop a second, right? How much is it for 2 milligrams for 30 drops in a minute? It's 1 drop every 2 seconds. This is 1 drop every 4 seconds. This is 3 drops in every 4 seconds. Okay, so we don't have pumps usually in EMS. So what do we need to do? We need to know how to make the constitution for utilizing the clock method. And then we need to know, like, okay, how much is 1 milligram? How much is 4 milligrams? And this is how we do it. But we need to have select concentrations like 2 grams in 500 mLs. How do you measure that? Like, yes, yes. That's exactly what you're going to do, Shrill. You're literally going to be titrating. I would use the smaller setting if you have a multi-setting for your drop setting. And I'm going to literally count the drops. I'm going to count my drops, and I'm going to say, okay, do I have 1 drop every 4 seconds? Okay, that I roughly do. That's 1 milligram. If I need to titrate it a bit and like let it kind of drop into the trash can for a moment while I'm setting it up, I'll do that before I hook it up onto my patient. And then I'll clamp it, and then actually no, I won't even clamp. Actually, no, I'm just gonna have it kind of like administered to my patient. I'm gonna slowly open it up. So like if I had my patient hooked up to this lidocaine here, I'm going to slowly open it up. I'm going to start counting the drops, and I'm going to try to make the drops just fast enough so I get 1 drop in 4 seconds, more or less. We're not going to get it exactly precise, but that's what we're going to aim for. But you're literally just going to be counting the drops and using a stopwatch. And if you want to be really precise, you can count and try to get 15 drops in a minute. What would I do? I would just check it once every 4 seconds, and I'd be like, did I only get 1 drop in these 4 seconds? 2 drops in these 8 seconds? 3 in these 12 seconds? Okay, I probably got it about 1 milligram. Do I have a drop every second? Okay, I probably have 4 milligrams. And that's what I'll use for lidocaine. Okay. You're going to use the clock method when utilizing lidocaine drips. You also use it, I think there's a method for norepinephrine. This is really complex pharmacology, by the way. This is about as hard as it gets for EMS. This and dopamine. Norepinephrine, EMS, premix bag. I don't know if they have premix bags in norepi, but you're basically, if you reconstitute norepinephrine, why can't I get a clear image? Come on, you. You're going to have norepinephrine. I've heard of dopamine clock. Is it the same thing, same principle? It's tricky. That one's too tricky for me to say. I don't want to tell you and then mix it up on you. But you're going to have norepi where you're going to, you should have protocols to basically make it into a premix. I forgot exactly how to do it. I'll have to look back at my protocols later. Maybe I can actually pull them up right now. Fire department. I have the protocols pulled up here. Norepinephrine's a very tricky one. Okay, that's how to use it. Does it say how to reconstitute it? Let's see here. Consider 8 to 12 unresponsive in a 500 saline bag. Do my protocols not say how to reconstitute it? Okay, look at this. Yeah? Oh. Okay, let me zoom in a little bit. Yeah, later on. Okay, so anyway, what we have here is we have our norepi. We can mix 4 milligrams in 250 mLs. So what does that mean for me? If I kind of clear up some of this nonsense, or I could just redo this whole thing here. I would take a 250. I need the number 2 real quick. This is going to take me 1 moment to set up, but it's worth it because it's really important for you to know. Let's see. So if I'm using the clock method for norepinephrine, saline, the way how I'd reconstitute it according to my protocols is I would take a 250 ml saline bag. I would then take, excuse me, norepinephrine, EMS. Let me see an image. Can I get a clearer image than this garbage image? This looks horrible. Is there a better image here? This is fine. This will work. Yeah, yeah. Also, this is going to be saved on YouTube for like a live videos. This is like number 6. So you can revisit what we just talked about with your questions, your comments, and just skip over to the parts you may have questions with. Because this will answer a lot of it, by the way. If you watch this once or twice and you kind of get the principle of this, it's fantastic. So, but what would I do here for norepinephrine? Is I would do the clock method, the exact same thing. And I would take 4 milligrams and I'd administer it in 250 mLs of sodium chloride. Okay, now I have my constitution. Now, we're going to do the same thing with the clock method. I believe it's 400 micrograms. Is it 400 or is it 4? Let me check one more thing. I almost had it all right. Norepinephrine. Ooh, it's not 400. Ooh, no. It's 4 micrograms per minute. So, 4 micrograms per minute at 15 drops in a minute. So if I reconstitute it by taking the 4 milligrams of norepinephrine and administering it in 250 mLs of saline, then I'm going to have the constitution for the clock method. Okay, so at 4 micrograms per minute, I'm going to do that at 15 drops in a minute. And my protocols, for instance, say to administer 8 to 12 milligrams for a patient, or micrograms to a patient. I need to borrow this too. Micrograms in a minute for a patient, right? And this is like post-ROSC if I can't get their blood pressure up after giving 500 mLs to a patient, if they have rails or fluid in their lungs, or 2,000 milliliters of fluid, and I still can't get their blood pressure up, and I'm like 20, 15 minutes away from the hospital. So, blah, 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 I'm doing the clock method. 4 micrograms per minute is at 15 drops in a minute. So how do I reach 8 micrograms per minute? Well, just going to double it. 8 micrograms per minute at 30 drops in a minute. And this is really good for you to know, Shrill. This is really, really tricky medic stuff, but the faster you get this, the clock method, the better. The clock method's awesome. Next, 12 micrograms per minute at 45 drops in a minute. Okay, see if I can make this a little bit narrower. It doesn't matter. Okay, and then if that's the case, what do you think this top one's going to be at right here? If we had to make a guess, we have 4 micrograms at 15 drops, 8 micrograms at 30 drops, 12 micrograms at 45 drops. What's this last one here going to be? So, at the, exactly. You are 100% correct, Shrill. 16 micrograms per minute at 60 drops in a minute. So let me ask you this. Using this clock method, if my protocols are, and they are, by the way, 8 to 12 micrograms per minute, what would I set my drop set to? What would I set it to? If my protocols said to use 8 to 12 micrograms per minute. But you're absolutely correct, Cheryl. Excuse me. Exactly. Yes. Let me throw out different emojis for you. Exactly. That's correct. You did a great job. You're 100% correct. In other terms, I'm going to set it between 1 drop every 2 seconds or 3 drops every 4 seconds. That's what I'm going to set it at. You got it. Congratulations. You learned the hardest part about pharmacology for a paramedic. That's okay, because we talked about it now. Again, these videos are saved. You can always revisit the topic, but also now you've got a little bit of taste for it, right? So now when you go into the clock method in pharmacology, now you're like, I kind of remember some of this, right? And even if you don't remember it word for word, at least now you're getting just a little bit of a touch of it, right? This is the beauty of the clock method. Dopamine works in a similar manner, but dopamine's kind of complicated for me to talk about. And there's different ways to calculate it. So it's something that I don't want to touch up on and then throw you off on. Let me do this though. As a paramedic, why do we use norepinephrine? Norepinephrine. We use it when someone is post ROSC and we can't keep up their blood pressure. Generally, some protocols will exactly. Yeah, it's like milligram per kilogram per minute. Yeah, it's a tough one. Generally, some protocols will say either first administer 500 cc's of saline. No, I'll say this first: 2,000 milliliters of saline or 500 milliliters of saline, and we start to notice. Hello, Adam. Good to see you, Adam Kizada. So good to see you. We start to notice that there's fluid buildup in the lungs. So we're administering saline to our post-ROS patients. Post-ROS just meaning that we resuscitated them. And we're trying to keep them alive now. But their blood pressure is kind of low. So we start to give them some saline. We notice after about 500 cc's of saline, hey, there's fluid in their lungs. What is this topic for? And of course, you can always join. Adam, you can ask anything. Right now, we're hitting pharmacology for paramedics, but feel free to ask anything. Anyway, so we start to notice after 500 cc's of fluid, hey, we're getting fluid in their lungs. If we administer more fluid, we're just going to drown them out. They're not going to be able to perfuse properly, and they're going to die that way. So we need to stop it. What can we do? We can administer norepinephrine. In my protocols, I would administer 8 to 12 micrograms per minute, okay, of norepinephrine to maintain their blood pressure, right? And really, we get a little bit of a range here between 8 and 12. Just pick one. Not a big deal. And just try to get the number in between and just kind of monitor them and then go from there. Norepinephrine is a scary drug because a lot of people forget how to use the clock method, but it's a good idea to practice every now and then, just so that way you can kind of build your competency. Besides that, I mean, that's a pretty good little review here for pharmacology for the main things for paramedics. Why do we administer lidocaine? We'll administer it for a couple reasons. We'll administer it as an antidysrhythmic. We'll administer it as a way to for a post-ROSC patient if they have like VFib or VTAC. And we administer lidocaine or didn't administer lidocaine. There's a couple different routes, right? Basically, as a paramedic, we will administer lidocaine, generally 40 milligrams in an IO site 1 minute before pushing fluids. If we are worried about pain for a semi or conscious, yeah, I would say semi-conscious IO. Or we would administer it as a dysrhythmic. That's misspelled completely wrong. Dysrhythmic medication. We would administer it as a dysrhythmic patient for someone in VFib or VTAC without a pulse. Okay. As a student, I personally recommend just learning amiodarone at the time, but some people slash agencies like using lidocaine instead. I learned it as utilizing lidocaine, but initially as a student, I learned amiodarone. But let's see here. Adam says, sorry, I'm just an EMT. Don't worry about it. But the epi is to try to get their body to self-correct. Is that correct? I'm trying to find the term for it, but I remember, if I'm wrong, that epi is produced when the body goes into shock. I'm not sure it produces epi for many reasons. Okay. No big deal. Adam. Okay. Adam. For epinephrine. Oops. As an EMT-B, you really just need to know that you're using it at a 1 to 1,000 concentration, 0.3 milligrams for an adult IM, and you're administering it for anaphylaxis. Okay, what does that mean? You're going to administer it to a patient. It's a patient that is having a severe allergic reaction. They may be presenting with hives, shortness of breath, general swelling, especially around their neck and their face. Adam, if you have a patient who's presenting with hives, what is the, let me see here, Adam, what is the medical term for hives? And anyone can feel free to answer that. It's a simple question to some, but if you don't know it, you literally just don't know it, and you need to for the National Registry. Answer if you. And I'll let you guys think about it for a moment. Does anyone know the medical terms? I'll leave it to anyone. What is the medical terms for epi? I know that I don't use or can administer. Oh, you can use it as an EMT-B. And why do mental health professionals want to force those who want to self-exit to live without giving objectives? That's a great question too. Follow Atheism Part 5. That's an excellent question. We can go into that too. Uh, Basically, Adam, let me see. Oh, the medical term for epi. I'm sorry. The medical term for hives. I'm so sorry about that. You're right. You're right. But what is the medical term for hives? We'll get into that also. Follow. Let's see. Yeah, you got it. You got it. I am on the live. What's up? No problem. No problem. So anyway, let's see here. What is a medical term for hives? It is urticaria. You need to know that, Adam, because it's not going to be written as hives for, and we'll go into that in a moment. Oh, that's okay, Adam. Not a big deal. The I'm only bringing it up because the National Registry is not going to tell you. The National Registry is not going to tell you your patient has hives. The National Registry is going to tell you that somebody has urticaria. And basically, what it does is your body. If this is your throat, I could just draw like a whole person real quick, and we'll get into your question to follow. It's not a problem. Uh, this looks horrible. This is your person, right? Oh, that looks horrible. Beautiful, beautiful person here. We'll draw a little feet too. Anyway, uh, what happens if somebody gets stung by bees? They have an overall reaction where they start to present with hives, and your body. Let's see if I can draw like a throat or your thorax, and you have your lungs here. There's your lungs. Basically, what happens is your body sends out an alert. God, this looks so gosh, this looks so horrible. Anyway, it has like a widespread like, hey, we're being attacked. There's a foreign pathogen, and it doesn't want the pathogen to get into your lungs. So you have smooth muscles that are here, right around your trachea and around your bronchioles. And the smooth muscle is basically going to constrict to stop the pathogen from entering into your lungs. And it's like an immune response to try to protect your body. But whenever it tries to keep the pathogen from going into your lungs, it also is starting to narrow the airway for your body. And as you get hit by envenomation or like bee stings usually is what it's caused, but just allergic reactions in general, your body starts to adapt and learn better, just like it would for a vaccine or any type of bacteria or virus. And it'll start to get better at closing your throat. And so every time you get stung by a bee, anything that you're allergic to or get exposed to that, your body gets better at responding to it, and it gets better at basically trying to hurt yourself and trying to close off the airway to your lungs. And so these patients, uh, oh, good, good. Sure, sure. Yeah, I'd love to answer it. Basically, your body is it's getting hit by too much venom at once, and so it's having a widespread reaction. And the biggest complication is that it interacts with the smooth muscles around your airway, and it constricts the smooth muscles. So we administer epinephrine, usually in like the side of the thigh, somewhere here. We can administer it in the glute. We can administer it in the deltoid, depending on where you hit in the glute. You have to be careful. And we administer epinephrine usually via an EpiPen or depending on how it's dispensed at your department. And one of the things that epinephrine does, along with increasing your heart rate, is it causes bronchodilation and releases the pressure in your bronchioles because it relaxes the smooth muscles. So this will kind of go away or it'll get diminished. And then your patient can breathe better, and now we can work with them, right? But every time you get stung by a bee or something that's caused an allergen, the reaction just gets worse and worse and worse. And eventually, if you're not fast enough, it can potentially kill them, right? So we have to be very careful. Okay, let's see here. Let me respond to this text and then I'll answer your question. Follow. Just papitas. Let's see. Beautiful. Okay, so follow is asking, and it's a great question. Why do mental health professionals, and I have to be careful because I'm on YouTube with answering this, want to force patients to go to the hospital when they want to, like how you said, self exit, right? Want to leave. this world. I guess that's a good way of describing it. It's a great question. Um, it's because we want to do no harm, right? It's because we want to do no harm. We want to get our patient access to healthcare professionals like an emergency psychologist as soon as possible. We we don't want anyone to harm themselves in any way. We don't want them to, how you said, like self-exit. And so we want to push for them to get the resources and get access to care as much as we can. Uh, a lot of times patients may not completely do something like this, and while it's not always the case, because it's really tricky to generalize this, it may be a kind of like a cry for help. And if that's the case, then we need to respond to that and try to get them again access to healthcare as soon as we can, right? It's very tricky when we deal with these patients because they may take too many pills or something like that. If that's the case, we need to consider activated charcoal very quickly to try to coat the pills and try to coat the esophagus, the stomach lining, things like that, and to try to make sure they don't absorb them as quickly as possible. Um, and if it's already absorbed, we may need to get their stomach pumped, and that's something that the hospital would deal with. I have personal experience with this sort of thing, and it failed. I still and will could have done that. Somebody could have done it as well if they wanted to. Yes, of course. We hope that you don't, or that anyone doesn't. But I mean, you have that option. But as far as for any medical professional is concerned, we want to try to avoid it as quickly as possible. And so we'll push for you to go see like a psychologist. Now the hospital visit is not fun whenever you have this kind of issues. Why is it not fun? Uh, because if it's too good of an experience, then sometimes patients will have like an issue where they will, what's it called? Patients will keep on doing that thing because it's their most positive interaction. And so we have like a tricky lining where we want to help you as much as we can. But if the hospital visit is too fun of an experience, then it may push them for certain patients to commit those acts more often. And you saw 51 to 50 cases. Often love to be able to see the reasoning behind it as well as these short-term holds. Yeah, it's very tricky. So when I got discharged, nothing was solved. So that's coherent proof. It doesn't help. It's not coherent proof because depending on who you see or where you're at, there's a couple things that it could be, right? It's really tricky to say. It gives you access to resources you might not have had. The visit is long, boring, and I mean, it can be long, it can be boring. It's just not an overall pleasant experience, and that can deter you from performing in that manner again, right? So we kind of want it to be not a very fun experience. But at the same time, we can give you access to resources. Maybe it can help with medications. It can give you access to certain medications to assist with this. The biggest thing is it giving you access to resources, giving you access to someone to talk to and to see how we can avoid from this happening again. Now, it's not that I'm confirming that we punish them. However, the visit can't be too fun because we don't want to get you to a point where you're like, okay, I want to keep doing this again and again. We want to get you to a point where you're not doing something like this at all, right? And so there's a lot of different psychology on the thought process on it too. So we can help access medication, can help access resources. It's not a very fun time. What else is there? However, there's some flaws with it. There's some flaws with it, right? Uh, for instance, for the place that I'm at currently, the longest someone can be at certain mental facilities, this is a big location by location basis. Uh, these places can only hold you up for like a week. Some places can only have these patients for a week. What happens after a week? They've got to let them go. And you'll see a lot of mental health patients are in this basically rotation. It's really sad to see where you're going to have a patient that's basically going to have a mental issue, right? They they go to the hospital. Let's see. Go to ER/psychiatric hospital, and then afterwards they are max seen 1 week. And then if it's like a homeless patient that has like psychiatric issues, things like that, they go back to the street. And then the cycle just kind of repeats itself because they can only hold them up for a max of a week. So thank you for confirming you punish those. I treat my mental health patients very well. And I try to kind of be like a light and a good resource for them. And I try to give them as good of care as I possibly can. And I try to talk to them about the positives and go from there. The only reason I went to there is because I had failed to prepare a proper method due to my established method solution to give horror and horror for person in anguish. I don't give horror and horror to people in anguish. I try to give them a reason to keep pushing. And I try to give them access to resources and recommendations and try to figure out the thought process on it and see if I can help them while talking to them in the box. So I think that this is kind of a hasty generalization, but I understand your frustration with it. I think it's valid. And you said get the exit method right the next time. That's what they taught you. It's a punishment. It's not really a punishment. We're trying to help you get better. Uh, and honestly, for what I would recommend for your case is to try talking to people about it. Try talking to psychiatrist, somebody who is more well informed, and maybe something like this, going to the ER, might be a good decision for someone like you or someone that's in your position. Uh, and hopefully they're able to help you get past it. Uh, I mean, I'm happy to answer things as well as I can, but you got locked in a room with nothing to do and there was a presence of other clowns. Well, that's part of it in an experience. But the biggest thing is getting access to certain resources, seeing what can help you. Um, but let's see. Since you have experience in this, does it ever put a strain on the holding facilities and the amount of homelessness that people that come to you? Kind of, but it's also part of the system, unfortunately, Adam. And then sometimes for like homeless people, for instance, this may be their only way to get off the street and get like a warm place to stay, and then food, and then somebody to talk to. So, mental health is always a really tricky topic to kind of discuss. But, we're always pushing for patient advocacy, for helping our patients. And so it may point them in the right resources like, hey, maybe somebody can go in and talk to them and say, hey, you can, there's like food pantry places. You can go talk to certain churches in your area. You can maybe, there's like assisted living, and then we'll try to bring up these patients. But some patients, unfortunately, they're so far with their psychiatric illness and they're homeless that they're just going to keep on repeating this system. And then that's where we get our repeat calls and our frequent flyers. But it's just a part of EMS. And so we try to show them compassion. It's not our job to judge them. And we just try to work with them to the best of our ability, get them to go see the help that they need, and then go from there. But it's tricky. It's tricky. I have had my frequent flyers plenty of times, and I'll keep on trying to give them the optimum care that I can. And I definitely have to put myself in their shoes where I'm like, and I've had to remind coworkers in the past and be like, okay, you know, these patients are, yeah, they're calling all the time, but look at them, for instance, right? Like maybe they're suffering from alcoholism and they're like, look, they have like weakened arms, weakened legs. They can't really walk anywhere. They have no family members. I understand that they're calling us a lot. They may just need someone to talk to. We may be the person they get to talk to during the ambulance ride. So I've had different instances where I've had to take different takes. So the resources don't coherently help. Therapists admit they don't get fix problems. They only try to get you to cope with the horror. Yeah, of course. We try to help with your coping mechanisms. And I can't speak for all therapists, but uh, learning different coping strategies is a huge part of mental health, right? Like trying to figure out, and again, I'm not a specialist in mental health by any means, but we try to go from maladaptive coping mechanisms where people may drink, they may do other things, to trying to have more positive coping methods like hanging on to a positive memory, trying to build yourself up. That's what we push for. I don't know what these words mean. Advocating for these philosophy is the main reason I live, to prevent other victims from being put into this bad place, something which a lot of doctors do care. I honestly think you're incorrect about that. There are a lot of amazing healthcare providers that really do care about healthcare. Coping is silly. I disagree with that. Solving the problem is what matters, and sometimes you can't solve the problems. And science and the reason demonstrate that it's rational to no. Uh, I disagree with a lot of what you're saying. I apologize if you've been having these kind of issues, but I just don't think that you're correct. I think doctors do an amazing job a lot of times, and I think that there are a lot of great resources that help a lot of people. I can't help it if you've been gone through this system and then it didn't work out for you, but maybe one day it will. And I hope that you consider coping mechanisms in your future. But I can only talk so much about mental health issues because it's not really my specialty. It's something that I have to deal with, but I can only recommend so much. And if you have any concerns, go get checked out. I think that when you learn to cope, it helps resolve issues indirectly. Yeah, I agree too, right? And we all have different coping mechanisms. In nursing school, I'm learning a lot about coping mechanisms and the different use cases for each one. And just learning about like the difference between like some people cope in a negative way, some people cope in a positive way. How can we encourage these patients to cope in a positive way? No, it wouldn't. I would rather do that than go through that again. Not interested in being punished by physicians. Okay, well, I'm sorry you feel that way, Follow. But I hope I answered at least somewhat some of your questions. But I apologize that you have had such negative instances. I've got to actually work on a psychiatric floor one time whenever I was shadowing for my paramedic school. And it's a tough system, but honestly, the nurses that I talk to, they all seem like they want, for the most part, a positive interaction with their patient and a positive patient outcome. That's not always going to be the case because mental health is so tricky, but you know, I've never seen anybody blatantly not care about their patient. Anyway, anyway, let's see here. I think it's an interesting topic to talk about, though, for at least for a little bit. But any other EMS questions? Let me see here. Any other EMS questions? Anything at all? And I hope that I was able to answer it somewhat. Even though I may disagree with your rationale, it doesn't mean that I don't respect your rationale. Let's see here. How do I open this? My dashboard. Yeah, coping isn't silly. It's how you go through life. I'm sorry that you don't believe coping is just silly. Yeah, and some people will have different takes on their life, and I respect it. Sometimes some people just won't go through things the same way as I will, and that's completely fine. I disagree, but I'm sorry you're feeling that way, Follow. If you do not have anything then you could ask me a question that relates to something that I learned or should know. Sure. So, switching gears a little bit. Uh, for stroke patients, what are the different types of strokes? And I appreciate the different thought provoking thing, Follow. It's just, I feel like we touched up pretty well on it. For EMS, what are the different types of strokes? Does anyone know? Tells me the name. Tell me the names of the cranial nerves. That's cruel. Adam, you don't have to do that. That's a tough thing to learn. Let's see. I was watching TV to get just this. Okay, let's just do this. Let's just let's just let him relax for about 10 minutes. I don't know if that's the correct method to dealing with it, but we're just gonna. There's like a timeout button. We'll just let him pause for 10 minutes and kind of regroup himself a little bit. Not saying that what he's talking about isn't a good or bad thing, but we'll do a little pause on that. Anyway, what are the different types of strokes? Does anybody know? It's a great question to ask. No, Adam, you're halfway there. So you just say it's a blockage of an artery. It's actually two different things. We can have, or really three, we can have two different types of strokes. One that's a blockage, cutting off circulation to the brain, like what you're talking about, Adam, or a brain bleed that compresses the brain, cutting off circulation. Okay, this can happen in some sense, three different ways. Oh my goodness. Follow, come on, man. I appreciate your conversation, but we're gonna have to pause on it, all right? We got to talk about other EMS topics, all right? You bring it up again, I'm gonna have to time out this account too. But you can subscribe with both of these accounts. I don't mind. All right, we gotta give him a little break here. We'll just do that. I give up. Anyway, also aneurysms are sort of related. You can use in that they can cause hemorrhagic strokes. So we can have ischemic strokes, a clot that cuts off circulation to the brain. We can have a transient ischemic attack, a clot that resolves itself and no stroke-like symptoms are present. This can occur spontaneously within less than 24 hours. Within less than 24 hours, or a hemorrhagic stroke. A brain bleed / aneurysm. How do I spell this? You spelled it. Aneurysm. No way, man. What? How many accounts do you have? I've tried to talk to you. Heck, please. A brain bleed. I'm trying with it, man. I don't know what else to say. A brain bleed aneurysm that compresses the brain. So, three different types of strokes. Really, it's two, but these two kind of fall in together. So you have an ischemic stroke, which is a clot in the brain that cuts off circulation to the brain and causes the stroke. You can have a transient ischemic attack, which is basically an ischemic stroke that resolves itself within 24 hours. Or we have a hemorrhagic stroke, which is a brain bleed or aneurysm that compresses the brain. All this basically is we're cutting off circulation to the brain. So is a transient ischemic just a sign or precursor? In a sense, yes. So if a patient does have a transient ischemic stroke, and it goes away after a little bit of time, well then they really, really need to go to the hospital because that's a sign like, hey, they might have gotten over this one. Uh, okay. How do I do this? Enough, enough. Uh, the transient ischemic attack is a sign that, hey, these patients or this patient is going to have a full-blown stroke pretty soon. And so we need to get them to the ER to get a CT scan right away and see if we can identify where the stroke is coming from. Is it coming from a DVT, something like that? Can we stop it from actually causing a full-blown ischemic stroke? So if I have the brain, can I show you what it looks like? Ischemic stroke. Let's see, ischemic stroke versus hemorrhagic stroke. This is a good one. This is from Healthline. But basically, you can see here that a block in perfusion can occur from either an ischemic stroke, so let's say if there's a clot buildup right here, or we can have a hemorrhagic stroke where there's an aneurysm and it builds up blood and compresses against the brain. So this will cut off circulation to the brain. They'll start to see hemiparesis or weakness on one side of the body. We can see weakness on one side of the face. We can see like facial droopage, things like that. Generally, what will happen is if you have somebody's face. Oh, this is crazy. How do I do this? Beautiful. We're going to block all of his accounts because now I've answered all of them too much. Guys, I've never had to deal with something like this, so not very good at it. Anyway, you have somebody's body, and then you have this. Right here. Yeah, sorry, guys. And so, if they have a, yeah, I guess so, right? If you have a right-sided stroke, you're going to see weakness that'll affect the, so if this is their right side, can I get a bigger brush? You're going to see weakness on this side of the face usually, and then you're going to see it on the opposite side of their body. So right-sided facial weakness, you're going to see it on their left upper and lower extremity, and then vice versa. It's basically going to cross streams. And so vice versa, if they have a left-sided stroke, you're going to see left-sided facial weakness. You're going to see left-sided or right-sided arm and right leg weakness. So the face is kind of an indicator where it's potentially at in the brain. Number 6. Yeah. That's another one. Anyway, so a transient ischemic stroke is where something like this occurs and it's partially like it occurs, but then it goes away, and then after it goes away, some patients will kind of like ignore it. We really need to push for them to go get seen, and there's some rules on strokes. For stroke patients, we want to ask a couple pertinent questions. We ask when they were last seen normal. That's huge. We ask what are they like when they're normal. What do I mean by what they're like when they're normal? Do they normally walk and talk without issues? Uh, do they walk with a walker? Are they normally confused? Because what if they fix the problem and then, like, let's say in a couple days or a week from now, or not a couple days or a week from now? Yes, yes. No, no, that's a great question. We're gonna get into it, Adam. Let's say they fix the issues and then they're in the ICU for a couple days and they're like, man, we can't get his speech back to normal, but that is his normal. We need to try to gather that on scene if possible. Usually it's from the person that called 911. It's like a family member usually, or like a nurse. So we ask when they're last seen normal. We ask what they're like normally. We ask if they take any blood thinners. It's really important to ask. Oh my gosh, again. Yeah. And we ask, have they had a stroke in the past? Okay, it's very important. We care about when they were last seen normal. Exactly, because if it's an ischemic stroke, if there's a clot, basically, if there's a clot, the ER staff can potentially administer TPA, just like he explained. TPA, it's at a place. Hey, Tactical, good to see you, buddy. Great to see you again. The window is generally less than 3.5 hours or between or up to 4.5 hours, I think. Or we'll just say 4 hours to play it safe. But I think it's 4.5 hours. 4.5 hours. That's generally the window where they can actually be administered on TPA. Don't worry, I got you, buddy. Anyway, hopefully he's subscribing with all those accounts. Uh, so the window is generally 3.5 hours or 4 to 4.5 hours. Now, that doesn't mean we don't take any strokes seriously. Like, let's say if they're past 4.5 hours, do we drive slowly to the hospital? No. All of these are code 3 calls. But if they fall within this window, as if they called 911 and they're like, hey, I had this weakness, it started an hour ago, then it's like, okay, well, we can go ahead and code 3, get them to the hospital immediately, and they can be administered TPA or at to place to these patients. Now, oh, dang it. He's not doing it, damn it. Anyway, uh, the important thing to know in EMS is the window that a patient can be administered at a place, TPA, which is less than 3.5 up to 4.5 hours. And also, let's see, the golden hour. The golden hour is from the time they called 911 to the time they got into the ER for a CT scan, should hopefully be within 1 hour. That's the goal generally. Now, just because you have a stroke patient, don't get too distracted. Like, you still need to ask some important questions like these, right? We need to ask these questions. So don't get too excited to where you get a stroke patient and you don't get a baseline set of vitals on scene, to where you don't ask what they were seeing like normally last time. If they're on any blood thinners, if they had strokes in the past, ask family members, get family members' phone numbers, and try to get them to follow us to the hospital too. It's very important. Let's see. No, we'll do that for like a patient for what is it called? For a stroke-like patient. Shrill, I see that you already know this, so I apologize. Oh, no, no, Adam, you can ask it. It reinforces his knowledge too at the same time, like teaching it. What's really interesting, exactly. is that patients who are experiencing a stroke will normally get two, where's the number two? They'll normally get two CT scans. The first is a CT scan without contrast, then a CT scan with contrast. And basically, contrast is like fluid that they can administer to a patient while they do a CT scan. Why do we start off with a CT scan without contrast if we're checking for strokes? So if we're checking for strokes, why do we start with a CT scan without contrast? This is more so ER side. You guys don't need to know this as far as EMS is related, but it's a fun little niche kind of bit of info to learn. So why do we start with the CT scan without contrast? Shrill, you may be able to do some like deductive reasoning and be like, maybe it's because of this, or maybe we're worried about this. There's kind of like two good answers for it. Let's see here. Does anyone know? The answer is first, because we worry about allergies for contrast. The second answer is because we are concerned of a possible hemorrhagic stroke. We don't know if they're having an aneurysm or a brain bleed, and if that's the case, we don't want that contrast to leak into the brain. Oh, don't worry, I got this. Put that right there. I was wondering if my chat worked, and then he popped up, and I was like, oh, okay, I got it. Anyway, so we administer contrast to a patient for a CT scan after we've done a CT scan without contrast, because we don't want to risk messing up with a hemorrhagic stroke. My answer didn't say I tried. Oh, it's okay. I believe you. But we're worried about allergies for contrast. We're also worried if they have a hemorrhagic stroke. So we start off with the CT scan without contrast. Let's see here. So what do you need to know in EMS regarding stroke patients? Really? You just need to know the different types. Ischemic stroke, transient ischemic stroke, or a transient ischemic attack, and hemorrhagic stroke. What's the initial CT scan without help you see if it's, it'll help you kind of identify like, hey, is this an ischemic stroke or not? And then you can kind of work your way down. Oh, it's not an ischemic stroke. Oh, there's an actual compression. We can get more information, or sorry. If we've identified, yes, it's an ischemic stroke, no, we're not seeing like a brain bleed, then we can be like, okay, let's administer contrast now and visualize things a little bit better. With the allergy, we're worried about with contrast. Is it because we use a dye, or is it radiotelp? It's tough for me to say. Just note that some patients may have allergies regarding this. That's tough for me to say, Shrill. I can't tell you exactly. But it is kind of a tough thing to answer. But the important thing is, know that there's an ischemic stroke. It's a clot in the brain. Know in a transient ischemic attack, it's a clot that resolves itself in less than 24 hours. Know that it's less than 24 hours, but they need to go to the ER because they're potentially going to have another stroke, and this one's going to be a bad one. Or can be a bad one. Then there's the hemorrhagic stroke, the aneurysm or the brain bleed that causes the stroke-like symptoms. As far as I'm concerned, this isn't something that's in the textbook, but generally hemorrhagic strokes are going to be a lot more aggressive. They're going to be acute. And even though it's not really written down that well, I have seen some slight examples of it. Generally, whenever a patient has really, really, really high blood pressure, usually the brain is trying to perfuse to itself, so it's building up more pressure against itself, and you're going to see that in hemorrhagic strokes. That's just off the dome. I don't know exactly the full accuracy of that, but from my understanding, incredibly high uncontrolled blood pressure, you're thinking that it's a hemorrhagic stroke. Which one is described as worse headache? That's usually for somebody who's going to have like a seizure or something, but I would say that's going to be hemorrhagic. I would say hemorrhagic shrew. You think of the worst type of strokes, hemorrhagic strokes. I think they have like a 50% mortality rate for hemorrhagic strokes. If they had a hemorrhagic stroke or any type of stroke, we can, what is it called? We want to get them to the hospital less than 3 to 4.5 hours. You will see a wide impulse pressure from a smaller bleed or a narrowed. Uh, the best answer, Adam. I don't know. I do not know. And I don't want to tell you an answer choice that's incorrect. I apologize. I just don't know. Good old Cushing's triad. Yeah, with the increased intracranial pressure. If we have Cushing's triad, what are we thinking? We're thinking increased, I believe it's increased blood pressure, decreased heart rate, irregular respirations. Right? Oh, is it narrowed pulse pressure? Let me see. Cushing's triad. Could be wrong. Widened pulse pressures. Widen pulse pressure. Increased systolic, decreased diastolic. Oops. Decreased heart rate and irregular respirations. There you go. I can't say because it's a patient by patient basis, but generally you're going to see an increased blood pressure whenever it comes to hemorrhagic. Like you're going to see a really high blood pressure. But we don't know. We can't determine whether it's a hemorrhagic or an ischemic stroke in the field. It's only like assumptions. We don't know. We can't determine this. Okay? I can't tell you in the field. So let me type this out. So I can't tell you in the field if it's hemorrhagic or ischemic. Why not? Why can't I tell you that if I respond to you in a 911 call? Because we can't do a CT scan exactly. Exactly. It's because we can't do a CT scan in the field. Exactly. Some places are like, oh, we should try to figure out how to put a CT scan on the ambulance. Why? It's not like we're going to fix it in the field. Oh, my goodness. Okay, thank you. But yeah, some people are really pushing like, oh, we need to figure out how to do a CT scan in the field. Again, like, what's it really going to change? It may change our TPA administration, but it's tough to say. Well, first, I'm not a doctor, and I can't tell you you're having a stroke. I can only tell you an informed guess. Yeah, and even then, what would my informed guess be? My informed guess, personally, for liability reasons, is I believe having a stroke, and just go from there. That's the best way to do it. So I hope that kind of answers some of your questions for it, Adam. Do you have any tips for my first FTO tomorrow? It's in 12 hours. Yes, I have heard of that before. You shouldn't tell your patient having XYZ just because you believe. Yeah, exactly, Shrill. You have to be kind of a little careful. Technically, we have what's called differential diagnosis. It's where we've narrowed down what the potential diagnosis is. However, we don't know the exact answer. I'm on a 911 ALS truck as an EMT, by the way. Fantastic. Lee, what would I recommend? I would recommend, Lee, to bring money to buy in with the guys. No, don't bring food. Bring money to buy in with the guys. Maybe bring a light snack just in case for them. No, don't bring food for them. You don't have to do that. If they're washing their unit or cleaning in the station, help them with it. It really shows a lot. Some ride outs that I have will literally just like sit down and watch us wash the trucks or clean up the station. I'm like, okay, that's kind of weird. Like, you're really supposed to be participating with us, but I'm not going to ask them to do that. No, no, do not bring them food. Do not bring them food, Lee. You don't need to do that. Just bring like a snack for yourself, and then bring money to buy in whenever they make food at the station. Um, what else do you need to do? Uh, be eager to learn. All right. So be eager to learn. Review the medic unit multiple times, right? So like what I would do is I would get up out of my seat, I'd go up to the medic unit and I'd look over my stuff real quick and then refresh myself a couple times, right? Go back to the medic unit, recheck it out. Go back to the medic unit, recheck it out. Pull out the stretcher, put it back in. Look over different like where like different medications are, what the monitor looks like. Mess with the monitor a couple times. Don't just do it one time like a lot of students will do. Um, bring some stuff to study. And more so, just, get used to pulling out the stretcher and have fun. That's really all I can offer. I mean, just have a lot of fun. Uh, put yourself out there and then make mistakes. Don't be too nervous to where you don't do your skills. It's okay if you mess up on a nasal cannula or putting on a non-rebreather, but don't miss out on the opportunity to do so. If you see them doing that, be like, oh, hey, can I assist you with that? Or hey, can I participate in that? They'll be glad you're participating if they're worth anything as a preceptor. And if you mess up, it's okay if you mess up. Every mistake you make while riding on the box is a mistake you won't do whenever you're by yourself. Thanks for the tips. I did ride time here, and I'm a little nervous because I'm officially on the payroll now. Well, congratulations. Yeah, just actively participate and be eager and check off the box multiple times, right? And just show like you're ready to learn and you're ready to like not be the best, and that's okay. Yeah, first time I had to do manual BP. Uh, don't worry about it, Shrill. I personally don't make students do manual blood pressures unless they really want to, just because I know they already have a lot of pressure as is, and I feel like they're going to kind of fumble it. IGELs really, I have not heard of an EMT being able to do so. It really depends on your protocols. Some state medical directors will let you do it, some won't. But later that day, I caught a triple A. Oh, I've never seen a triple A in the field. That's awesome, honestly. And you can do EKGs. Yes, most EMS agencies, once you get start to write out, they let you do 12 leads. But again, it's up to your medical director and also the paramedic that you're working with. Super cool. I'm really lucky to be at the department. That's so great to hear, Lee. Catching a let's see here. I'm just gonna do this. Catching a AAA is huge. Usually, Adam, you're really going to want to know what to look for test wise. Nice. The pulsing in his abdomen, so forth. The key term is tearing sensation. It's a tearing sensation, is what you're looking for, Adam. So if you ever see an NREMT practice question and you're suspecting a possible AAA, look for a tearing sensation. As soon as somebody explains that they have a tearing sensation around their upper chest, abdomen, their throat, suspect a AAA, and that's generally the answer choice. AAA would be tearing pain in the stomach and would be, and then the difference in the blood pressure in their arms, if I remember correctly. I think you've got it, Lee. I've never identified one in the field. I've never had a patient with one because they would have died like instantly. But it's always something to look for. If you hear somebody describe a tearing sensation at all, your eyes should widen a little bit because they've got a very short time to live. Let's see. Okay. With that being said, guys, I'm probably going to wrap it up. Yeah, my eyes would widen too. I'm sure everybody's did. If you're looking for a test prep, I'd always recommend. Yeah, I would be freaking the heck out. .com. We have a great study bundle there. So I'd always recommend amateurmedicine.com. We have a great study bundle for the NREMT-B. Before you go, can you explain Cardizem to me? Yes, I can really quick. I can do that for you. Cardizem is used for AFib. I'll do that. RVR. What is AFib RVR? AFib RVR is an accelerated atrial fibrillation. Basically, they're going to have a really fast heart rate. Check your. Oh, no problem, Phil. It's good to see you, buddy. And I'll be tuning in to stay sharp. I really appreciate your time, buddy. And check your local protocols. No, all I know for Lee is that you're going to administer it for AFib RVR. To see the rate they define as AFib RVR. I've used Cardizem before. It has like a weird dose. I think it's like 0.35 milligrams per kilogram, then 0.25 milligram per kilograms, or vice versa. I think it's 0.35, then 0.25. So check on the dosing on that and check on what you're considered as AFib RVR. I think it's greater than like 120 beats per minute or somewhere around there, like 120 to 160. It resets the heart. We prefer Cardizem resetting the heart over synchronized cardioversion for AFib RVR, because if we synchronize cardiovert these patients we can potentially disrupt a clot causing a pulmonary embolism or a ischemic stroke. And then, so what we do is we administer Cardizem. Really, a lot of patients can have AFib and they're fine. It's really if they start to present with symptomatic, they start to have like an altered mental status, they start to become weak, and it's their first time having AFib. We can consider converting it, but I would contact medical control before converting it. I'm always going to call medical control before doing synchronized cardioversion, but Cardizem is an option. I've done it before on a patient who was presenting with weakness. It worked really well. These past streams, I always get the notification, but I'm in class. But fate decided that I caught this stream. Well, I'm so glad you're here, Shrill. Again, Phil, great to see you. Adam, if a AAA happens in most scenarios, then just drive quickly to a trauma facility, your best one. Update on nursing school. How's it been? Fantastic. I feel like I'm doing a really great job. I'm going to tutoring a lot, passing all my tests fairly well. Uh, but tutoring is my saving grace. I'm halfway through my clinicals right now, so I'm really enjoying it. And I'm really enjoying all the education that I'm getting. My instructors are amazing. The tests are hard, but if you study for them, you should do fairly well. And they give us nice curves at the end. So I'm really lucky for the program that I'm in currently. But besides that, again, if you're looking, I gotta always plug my stuff, right? For a test prep for the EMT-B, I'd recommend amateurmedicine.com. Stop by next stream and let you know how the shifts at. Yeah, let me know. I work the next 2 days, but you can always join our Discord. And if you do, I'll try my best to answer anything. Let me see here. Let's see. I hope you guys have a great rest of your day too. But yeah, I'm always happy to answer questions to the best of my ability. I'm gonna be at work the next 2 days, so we'll see whenever we have time to do this again. I'll see you guys later. See ya. Oh, nice. Cool.